Okay, we're going to go ahead and get started. It's February 17th, 2022. We have our PACU resident, Patrick. I'll let you introduce yourself and give a little background.
Sure.
When you're ready, I guess, well, we'll try to share from here and start. Let us know, guys, at home if you, for whatever reason, can't see the PowerPoint. You put that in the chat. Okay, so then
I can see it.
Okay, cool. Thank you. That's a part. Hi, what do you think I should hide? I was trying to get rid of that top.
Oh, you can do it. It's fine.
Okay, all right, take it away.
All right.
That is the
This-
sound bar
it's
for
working.
your video, right?
Cool, yes.
So hopefully that works.
All right. Awesome. All right. Hi, guys. I'm Pat. Mind the way there.
I just say I can shove that over.
Oh, yeah. I'll move it over here.
Okay.
All right. I changed my topic a couple times because I wanted to find something that was like I felt like was relevant. I know blood transfusion reactions are definitely relevant, but I investigated it yesterday and I called the blood bank and they're like, yeah, just basically call the blood bank. We'll sort it out. So I felt like this might be a little bit more hands-on. But I'm going to talk about tracheostomy and laryngectomy emergencies today. I'm Pat Larabell. I'm one of the CA1s. The reason why I chose this topic was because overnight on Monday, we had a patient that came in that had a very challenging tracheostomy placement a few days prior and came from the floor he was hypoxic and his trach was thought to be displaced. It just kind of spurred me to do this topic because I think these patients are scary, and any initial steps I think are helpful for anyone that takes care of these patients. So there it is. All right, so for any tracheostomy emergency, if there's three things that you take away from, if there's like one thing to take away from this lecture, you should have these things on your mind. So one is the tracheostomy tube obstructed. Two, is it out of place or is it dislodged? And three, is the problem associated with bleeding, which can be a severe problem. These are a couple different pictures of how a patient with a tracheostomy or laryngectomy might look. And we'll talk about the difference between the two and what implications that has for the management of these patients. But you can see some people just have a stoma, some people have a trach collar in place, some people have metal trachs, but that's less common, I feel like. And so I think it's important to think about, why are the reasons that people have tracheostomies? And that will help you understand like what you need to do in the specific situation. So most commonly, I think we see people with chronic respiratory failure, patients in the ICU who have a prolonged mechanical ventilation, can't be weaned from the ventilator, and so they have a tracheostomy tube placed. Some people that we see often in the PACU are like head and neck cancer patients with head and neck with obstructing masses that require a tracheostomy for airway protection. And then the last common category is probably a failure to protect the airway. So these are patients, usually like neuro patients who have strokes, who have a tracheostomy and a PEG tube place because they have high risk for aspiration. Some basic tracheal anatomy. So the important things to know are the thyroid cartilage, which you can feel that's your Adam's apple. The cricoid cartilage is below that. You can probably feel on yourself your cricothyroid membrane. That's where people go for a cric or a cricothyroidotomy in an emergency situation. But more typically in a controlled situation, surgeons will do a tracheostomy, which is typically done between the second and third tracheal rings in this box outlined here. And the reason for that is because if you go too high, then you might be into the vocal cords or the larynx itself, or it might be too close. And if you go too low, you can run into issues with the trach being displaced or bleeding problems. This is how a tracheostomy is typically done in the OR. You have your exposure, make your initial incision. I don't do any of these, but this is what I understand. Sometimes you have to divide the thyroid, then you get down to the trachea itself. You can make this vertical or slit incision, or you can do something else called a Bjork flap. And this is where they kind of cut the ring in half and pull this part of the trachea forward, which they suture to the skin, which will help prevent dislodgement or creation of a false passage. because it kind of reinforces that area. This slide also, important takeaway is that the thyroid is very vascular. There's very vascular structures around the tracheostomy formation. And so bleeding can definitely be an issue. You can see the inferior and superior thyroid arteries. They can definitely cause significant bleeding. You can run into that when doing a crike. It can just be like a really bloody mess. Hopefully it's not most of the time, but that's why it's best done in a controlled fashion. There's also percutaneous trachs, and these are done in the ICU. It's typically done with like a Seldinger technique. So someone will place a needle through the appropriate space. You can look on bronchoscopy, you can see the needle come in, which is what this little tiny picture is trying to show here. And then you have these serial dilations where you put one of the blue horns on, then you pull it off and you put another one on, and you eventually put the trach in. And that's nice for patients, these ICU patients that are unstable, don't really want to transfer them. The outcomes are pretty similar to doing an OR-based trach in terms of success rates and complications. So overall, it's not a bad option. This is an open trach in a real person. Some basic tracheostomy anatomy. So I have a Shiley here. I was going to open it, but I think it's part of the emergency cart, so we'll just leave that as it is. But it's made up of an outer cannula, an inner cannula, and an obturator. This one in particular is cuffed. And so that's important to know. The inner cannula is really important to know about. So, and I think most people do know about that, but basically there's an inner cannula in the tracheostomy tube itself that serves as like a function to prevent an emergency situation. So if you have that thing clogs up, we've all seen those patients that cough up a bunch of secretions. If that gets stuck, you can just take that out and then you have a patent airway in place that's stented open by a tube. Whereas if you don't have that, it can be a little bit challenging, especially with a fresh tracheostomy. You don't necessarily want to pull that out. The obturator is used for placement of the trach, so that's typically not going to be there, but that's just something that's used to guide the trach into the right place. And then people use plugs or caps when they're about to decannulate. So this is just a real picture. The one thing I wanted to take away is you can see on the flange itself, it'll say the size and some basic information about the trach. So this is an 8 fenestrated trach, and it will tell you the internal diameter, which is actually 7.6 millimeters, and the outer, which is 12.2. So even though it says it's an 8, if you look here, these things, all the different brands have different numbers, but it does not really correlate to the actual size. It's like a rough estimate. So the Shiley 4 is, well, this one, for example, the Shiley 6 is actually a 6.4 millimeter internal diameter. So it's actually a little bigger. Some of them are smaller. This chart is, I don't think it's actually accurate, but it's just one thing to know about. There's different types of tracheostomy tubes. Some of these are fenestrated. That allows air to go up through the vocal cords, which can help patients speak. This is the obturator in place. Some people have metal trachs. I think they're less common. Apparently, it's cost effective because you can sterilize it. They're less prone for infection. One thing you might notice is you can't really hook up an ambu bag to some of these trachs though, which can be problematic in emergency. Some have adapters for that purpose. And then there's like custom size trachs, XLT, like a Shiley XLT, either has a longer proximal portion or a distal portion, which can be helpful for patients with like a lot of soft tissue in the front of the trach. It's a longer proximal portion. And then if they have some tracheal stenosis, perhaps you would use a longer distal portion. So that's what they look like. Some patients will have speaking valves. So this valve functions by you're able to breathe air in, and then you're not able to breathe air out of it. So they typically do not have a cuff, but the air will pass back up through the vocal cords for the patient to speak. And then some people have caps, which they do like a cap trial to see if they can tolerate breathing out around the trach in preparation for removing it. So some of these have like some self-deprecating humor towards medical students and residents, but a 57-year-old woman with a tracheostomy tube secondary to head and neck cancer is admitted for bacterial tracheitis and infection of the trachea, and she's found unresponsive on the floor. The medical student tried to ventilate via the trach, but very difficult to bag. So the SAT is 70% and declining. So I think for any trach patient, there's a couple of pieces of information you want to try to obtain as fast as possible. Why was the tube placed? Is it because the patient has absolutely terrible cancer that no one could intubate the patient for from above, and this was an emergency? Or is this someone who had like a traumatic brain injury and has a totally normal airway? Is it actually a tracheostomy or is it a laryngectomy? And we'll touch on this later, but a laryngectomy has no connection to the mouth. So they cannot be intubated from above. And that's important to know because that's like your last step for these patients is to intubate them when they're really having respiratory distress. So the other one is how old or new is it? A fresh trach is that the treatment for that is very different from an old one. These old ones, oftentimes they're very easy to replace. You don't need to do a lot of special stuff. In the OR for a lot of these patients, we just take the trach out and put the tube in through the stoma with no issue at all. But new ones can be complicated. And then what kind of trach tube is it? Just for getting like a rough estimate of the size. Most of these patients have the same size trach and one smaller and one with a cuff. And it's important to know if it's cuffed or not. And then like, what was the preceding event? This patient in particular had secretions, but were they bleeding? Were they coughing? A lot of these patients will cough their trach out. So in this case, we consider, is this thing obstructed or is it dislodged? And the history of like, this was hard, they put a bag on it, was hard to bag, makes me think that it's more obstructed, but dislodged could also be the case. If you're thinking about obstruction, again, mucus gets blocked up in it. The easiest thing to do is suction it out or take out the inner cannula, and that will resolve the obstruction. Alternatively, sometimes the trach can get pulled out a little bit and it'll be stuck up against the back wall of the trachea itself. And these patients can be hard to ventilate. It's not technically out of the trachea, but it's not functioning. And then finally, sometimes a false passage can be created where someone, maybe the trach popped out, they try to put it back in, hooked it back up, they're not getting any end-tidal CO2, they're not able to bag, and that's because it's in the soft tissue, it's not in the trachea. So that's that picture on the right there. So one thing I wanted to highlight, there's a project in the UK called the National Tracheostomy Safety Project. And this was like a project created by some British, I think anesthesiologists, or intensive care doctors. We saw like some patients had really bad outcomes because people didn't have a standardized approach to how to treat these patients. They are scary. So they created a couple things. One, like a system to signal what the patient actually has going on. Do they have a laryngectomy? What kind of tracheostomy do they have? What size is it? What size is it? And to have this with every patient, so you're not struggling to find the stuff out. It's right there by their bed. The other thing they created was an algorithm, which we'll go through. But it's like a ACLS type algorithm that you can just reference. And so is the patient breathing? No, then you start CPR. But if they are, then you're going to want to see if in this case, if the trach is patent. And so what you do, if there's any cap or anything covering it, you just take it off and see if you can pass air through it. And you listen, you see. But before you do any of that, you're going to just place oxygen on the patient. And something that's important to know for these tracheostomy patients is that you think like, yeah, everything needs to go through the trach, but they can often breathe through their mouths as well. They might not be well, but they still can. So you put either a face mask or any type of oxygen on their face and over their trachea. But anyways, you take out the cap. You can try to pass the suction catheter through the device as it is. You can also just take out the inner tube. You can see if that resolves the issue. And then you pass the suction catheter to see, number one, are you getting a bunch of secretions out? But two, will it actually go anywhere or is it just stuck against something? And if it doesn't go anywhere, the next thing to do is actually, if it's a cuff trach, to deflate the cuff. Because sometimes the trach is partially dislodged and the cuff is up. And so no air is going through the trach. The patient can't breathe through their mouth. But if you deflate the cuff, then they might be able to actually move some air through their mouth, which could be helpful. And then that comes down, like the last step, this is one I give with a caveat. The last step is to remove the tracheostomy tube. So this specific project, like their paper said that everyone is very hesitant to do this. Like you're not supposed to touch these trachs. And certainly in a patient with a brand new trach, like within a week, you should think very hard about removing a tracheostomy tube. But sometimes if the tube isn't working and you're not having any success with anything that you do, taking it out and just letting them try to breathe through the stoma is an option. Now, I would probably recommend like, the most important thing, which I did not mention, is like you call for help right away, of course. But before taking the tube out, it may be worthwhile to get help to the bedside and have whoever it may be to help you out with this. And so if that works, then you're good. You have time to like replace the trach properly. If it doesn't work, the final step is they're still not breathing. You took the tube out, then you have to try to ventilate them. And often we go to like bagging them on their face. That's just what we're used to. If you bag someone over their face and leave the stoma uncovered, the air will just come right out. So you should try to cover the stoma at the same time. If that doesn't work, you want to cover the mouth and try to bag through the stoma. And you can use either a pediatric sized mask, or you can use an LMA. If none of that works, you want to prepare just to intubate from above if you can. So this is kind of the algorithm there. This is just reviewing the causes. This is the video. These guys, this is the video associated with the project. Oh, it doesn't look like it'll, oh, there it goes. They're just like so calm about this whole situation.
You okay there, Sheila? Breathing. Okay. Can I have some help? Just going to pop some oxygen on for you. Hello, James. What's going on? This is Sheila. She's just struggling with her breathing. Would you be able to apply some of that oxygen to her mouth as well, please? A bit more oxygen, Sheila. Might help you feel better. I know she's got a speaking valve in. Will you be able to remove that and remove any inner tubal circuits? And she has got an inner tube. Pop that out. Thank you. Would you be able to reassess the breathing now, please? Still not happy there, Barry. Could you try and pass the suction cap to them, please, James? No, I couldn't pass that. Just going to take this tube out, Sheila. Grab an ambi bag for us, Barry.
There's like no good outcome in this scenario. That was it. So, but you know, like that's not what it actually looks like. The patient's like coughing and everyone's freaking out and it's scary. So it's hard to go through those steps. That's why like a checklist like that can be helpful. The next one we'll go through quickly, but a patient with a TBI just with a trach was brought to the PACU from the OR. You know, she's agitated, she's thrashing, she can't really say what's going on. Her oxygen saturation is 85. You see her trach is just sticking partway out. So anesthesia resident sees that and just pushes it in and goes back to charting the vitals. And then her sat just keeps dropping. And so you get your 30-second history. You know, this is an old trach. It's a tracheostomy. It's a size 6. It is cuffed and the cuff is up. This one, you know, it makes me think about a dislodged tracheostomy tube. So it was already out of place. And then someone just came in and just pushed it back in kind of blindly. It's not always the wrong thing to do, but you should be very careful about assessing if it's in the right place or not. And so this brings us to, like, what do you do with a fresh trach? So the reason why a trach less than 7 days old is such a big deal is because it takes a while for that stoma to really mature. And if you have a trach that pops out or it's dislodged and you just try to push it back in, there's a high risk of causing a false passage. So putting it into the soft tissue and not the trachea. In these cases where patient is really declining, some people advocate for just trying to prioritize intubation if you're not seeing an easy solution. But that's part of the algorithm going down it. Anyways, there's another thing you might see often is these stay sutures, where patients have sutures that are sutured in place to the trachea itself, which can literally be used to grab and pull the trachea up to the skin and make it easier to put the trach back in. That's what they look like. That's why no one's supposed to touch them, and they're taped because if they get crossed and you pull them the other way, then they'll close the trachea, which is not good. So for trach dislodgement, you're going to do the same things. You're going to call for help. You're going to apply oxygen to the patient right away. Most of these patients will have a tracheostomy with them, but if they don't, you want to get one of the same size and one smaller. When these come out, sometimes people come in from home and they've been out for a while. The stoma will start to close, but right away it should not start to close immediately. And then depending on the age of it, if it's really old, this is like a patient who's had a tracheostomy for 2 years. It's very, in the OR, they just pop it off and put it back in. Sometimes just putting it back in is the right thing to do. If it's new though, using a fiber optic scope is recommended to make sure you're absolutely in the right place. And so we call for the airway cart. I have this Aintree stylet here, or airway device. You can use this for different things, but one thing to know is that it won't fit in a 6.0 tube. A 6.5 would be tight. A 7.0 tube would work for an endotracheal tube. And this is a case study of where someone, they put the trach tube over the fiber optic scope, but were unable to pass it in because the scope was bending. So they used one of these devices, able to kind of guide it in there into the right place. Some people talk about using a bougie to also place these things in the right area, but it's very stiff, the ones that we have, and you could cause some trauma doing this blindly. So it's a little bit controversial. All right, the next one, this is a patient with laryngeal cancer with trach. They've had it placed 3 weeks ago, and they're coming in with, they had a little bit of blood, like a couple tablespoons. They said nothing, no big deal, but they wanted to get checked out, make sure it was okay. But they're hypoxic on trach collar, and they look like they're working to breathe. So of note, you see the record, and they are able to be intubated from above. In this case, we do the same thing. It's a trach. It's relatively new. It's within the last 3 weeks. Size is what it is, and they've had some bleeding. So a bleeding trach. The thing that is scary about this is that you can have like a really life-threatening bleed from something called a tracheostomy fistula. It's like the feared complication associated with trach placement. But you need to consider, that's one thing to consider in trachs that are new. But with any tracheostomy bleeding, you have to think about what is the cause. So is it a nosebleed that's bleeding down? Most commonly, it'll be some mucosal irritation or some granulation tissue at the site of the trach, or from aggressive suctioning. And then from below, is this someone with like hemoptysis for some reason, PE or something? The timeline of bleeding early, like right after it's placed, is usually from manipulation or cutting through the skin itself. Later is this granulation tissue or inflammation, infection, erosion of blood vessels, or this tracheostomy fistula, which we'll talk about. So this is the innominate blood vessel, or the brachiocephalic artery on the right, crosses right over the trachea, comes right off the aorta. It's a big blood vessel, a lot of pressure. Sometimes a trach can actually work its way through the trachea itself and create a passageway between the two, which can cause life-threatening bleeding. It's extremely rare, but the thing that everyone is scared about with these trachs usually happens within the first 3 to 4 weeks, and up to 50% present with like this, oh, it was a minor bleed, there's a couple tablespoons, that was it. So you have to take these things seriously. This is what it looks like. The trach, based on the position or the cuff eroding, will get right into that blood vessel, which sits right underneath the sternum, and they can have massive bleeding. Sometimes these patients will get rushed downstairs because of this. Obviously, you're going to call ENT. Really, the first step is to look directly if the bleeding has slowed. You can also consider getting a CT angiogram. And on the CT, you can see the bright white is the aortic arch and brachiocephalic or innominate artery. You can see like a tiny bit of contrast that's like leaking into the trachea, which is the black part. Oh, there we go. So if they're actively bleeding, it's a little bit graphic, but these can be life-threatening, bleeding out in front of you type things. And you have to have a method for trying to approach. They still have a very high morbidity and mortality. In this case, this is a picture of someone with a trach in place. So I'm trying to hold pressure and actively doing a sternotomy to try to get control of the bleeding. So the first step is actually, if they have a cuffed trach, to blow up the cuff to a really high pressure with like 50 cc's of air. What that will do is hopefully tampen off that bleeding. And you can see this picture here. The blood vessel is being smushed by all the air in the balloon. Alternatively, what you can do is put a finger in the tracheostoma itself and put pressure behind the sternum. And that will, in an attempt to close off the blood vessel. And someone just has to hold that until they get to the OR. The last thing you can do is actually put in an endotracheal tube. You take out the trach and you put the balloon in from that and you blow it up. So the final thing we're going to talk about is a patient with a history of COPD and a laryngectomy for head and neck cancer comes in with respiratory distress and hypoxia. And this is an old laryngectomy. He's got his tube in there, but he's retracting, he's tripoding. He's supposed to come in for just a routine surgery, but now he looks really, really awful. So in this case, due to your history, he has a laryngectomy, so he cannot be intubated from above. There's no connection there. This was placed for cancer. It's old. He has a tube in there, and he's just having difficulty breathing. So that's what this looks like. They usually have a larger stoma and the bigger tube. This is what the connection is. There's no connection between their trachea and their esophagus and larynx anymore. It's usually resected. So they can eat and stuff, but there's no connection from like their mouth to their trachea. A lot of people will have this prosthesis or a TEP valve in place to help them speak. They usually have a tube in there just to maintain the patency. That's what they look like. They're usually bigger. This is an example of a laryngectomy sign. This is the same society's algorithm for laryngectomies. And the first thing is to call for help. Second thing is to see if they're breathing or have a pulse. The third thing, then you apply oxygen, but you don't apply it to the face because you're not going to get oxygen from their face to their lungs. You only apply it over the stoma. If there's a tube in there, you can do the usual troubleshooting by taking off any cover. You can take out an inner tube. You can pass a suction catheter. You can deflate any cuff. And then ultimately, if they're not improving, you do the same thing. You apply either a small mask or an LMA over the stoma itself. The last step in the process is to place an ET tube down there. Sam gave me these slides. He said that this is from a study of ENT docs. It said that 50% of ENTs polled had a laryngectomy patient that was attempted to be intubated from above, which is impossible. So it's just, that's the main takeaway from this, is that they cannot be intubated from above. And 26% of people who attempted intubation were anesthesiologists. So people who should hopefully be familiar with that. But still, it's a challenging situation, especially in I actually saw this patient in the ED. They had their TEP valve, it fell out into their trachea, which caused them respiratory distress. So ENT actually pulled it out at the bedside with immediate improvement. That's that little device that fell there. And then finally, like the last thing here, we do have a difficult airway process. You're probably familiar with it. It'll say difficult airway in the chart. Like anyone can create a difficult airway sign. There's a navigator for doing that. I guess the criteria specifically is if they had beyond routine management to secure their airway, or they required 3 or more attempts. Hospital policy requires you to use this. It's recommended that you use this. And then if the patient is readmitted, the last service that updated the navigator should be notified that the patient is here. And then if you look in the patient's chart, like really helpful in a situation where someone is crashing. Very difficult, no difficult airway. If you click on that flag, this will pop up. And there's usually some information in here that will say why, why are they difficult? Why do they have a difficult airway? There's some schematic that you can see, like put here, that they have a trach or radiation. And then any special equipment that's needed, any special services. So it's usually ENT, but yeah, that's it. So if you encounter another tracheostomy patient, the three main things to think about is, if they're having distress, is number one, is it a trach or is it a laryngectomy? But is it obstructed? Is it dislodged, or are they having like massive bleeding? You need to be really worried about. And that sentinel bleed is something that you should definitely make the team aware of. So that's it. Does anyone have any questions? All right, awesome. Thank you. Let me see. No. Oh, thank you.
Good job, thank you. I'll share the PowerPoint then with the staff for like the Zoom.
Okay,
Just so
awesome.
people can't, if they couldn't log in today, that they can watch it later. So. All right, thank you. Thanks guys for joining in. No, yeah. Ethan, Wendy, Sarah B. Did you have Vicky too? Okay. Somebody's not on mute.
That's a lot on there.
There's a lot of people. Thanks, guys.